Today we have Professor Sarang Dev, Executive Director, Max Institute of Healthcare Management and Professor of Operations Management, LISB, in conversation with Dr. Praveen Geddam, IAS, Additional CEO, National Health Authority. They'll be discussing about National Digital Health Mission, its early experience and way forward. Just to introduce further about Dr. Geddam, Dr. Geddam is the additional chief CEO of the NHA, as I mentioned. He has been in charge of policy formulation, design, and implementation of two flagship healthcare schemes of the Government of India, the Ayushman Bharat and the MIHM. A career bureaucrat, Dr. Geddam was also a medical doctor before he joined the Indian Administrative Services in 2002 in Maharashtra cadre. He has held several important positions in his career and was the private secretary to Union Cabinet Minister of Railways in the Government of India. He has earlier served the state government of Maharashtra in various capacities. He was Transport Commissioner of Maharashtra, where he spearheaded a massive computerization exercise. At the cutting edge field level, Dr. Geddam was responsible for critical government interventions concerning socio-economic development, including those in public health. He is known for the turnaround in maternal and child health indicators in the state of Maharashtra due to targeted interventions, systematic medical checkups, and massive community mobilization exercises. In 2015, he planned and managed Kumbh Mela in Nasik with zero missing, zero outbreak, zero casualty record, the first ever for any Kumbh Mela. Many best practices developed and implemented by Dr. Geddam in various fields have been acknowledged and scaled up as policies at state and national level. Professor Dev, I now hand over the session to you to talk a little bit about what we do at MIHM and also kind of start off with the discussion. Over to you, Professor.
Thank you, Soumya, and thank you, Dr. Praveen, for finding time for today's event. You've already had a very long night and probably a busy day ahead after this. Especially in a year like the 2020 and 21, health is at the forefront. You have many competing priorities, and we are glad that you could find time. I think also because what has happened in 2020 and 21, health is on everyone's top agenda. And so people are curious to know more about what's going on. So I guess before we get into the topic, which is the National Digital Health Mission and its future scale up and rollout, I wanted to talk about your first baby at NHA, which is PMJ and Ayushman Bharat. You've spent a couple of years on it right from the beginning. And I thought it would be useful to hear from you what would be your scorecard of PMJ today? What are the things that have worked well? What have been the big wins? Also, what are the remaining sort of milestones to reach in the near future? If you could start with that, and then we'll switch.
So, thanks, Professor Dev, ISB team, and Max for having me with you. When the Ayushman Bharat was conceptualized, sometimes in early part of 2018, and we were tasked with rollout by September of 2018. The time remaining was very short, and it was necessary to scale it up very fast across India. Now, there are few challenges. The most important challenge is, unlike in certain countries like UK or other smaller countries, all the Indian healthcare providers, they are not under the same management. Health is a state subject, so we have 36 states and union territories managing their own hospitals, then private hospitals, then Government of India, various ministries managing their healthcare facilities. And it was necessary to bring them on board at this scale in a fast manner. That apart, it was also necessary to identify beneficiary selection criteria, which will enable the scaling up and correct targeting without much red tape. So it was decided to use. So we have certain good databases like census, which we cannot use for legal reasons. So we went for what we call SECC database, socio-economic caste census of 2011, and certain criteria were identified. So this became a entitlement-based scheme rather than a enrollment-based scheme, which allowed the scaling up to 54 crore people very fast. Then there was another challenge. Government is already implementing health assurance schemes like CGHS, and the model of payment in these schemes has traditionally been fee for service. Now, this may not work at this scale when we are dealing with population twice the size of US. So we then designed what we call health benefit packages, and then later on improved also these to make things simpler. And needless to say that since we digitized everything, the operations become fast and smooth. So this was actually a very massive exercise which went behind the scene before the program was launched in September 2018. There are some challenges because I'll just tell admin side challenges first. We actually finding it a bit difficult to explain to the individuals about the eligibility criteria. They are slightly difficult to understand for a layman. It's a different issue that the list is already prepared and but that is one area of communication which we find difficult. Then we have to balance the interests of private and public sector both. We have to ensure that a certain profit can be made by treatments at this level, but we also cannot allow our public exchequer to just pump in money without corresponding outputs. So to constantly revise the rates of packages, that is another challenge. And as I told you, to take 36 union territories and states, out of which 32 have joined so far, on board, and to adjust to the working style of those states. These are the continuing challenges that we continue to face, but so far it's going on smoothly, and we look forward to further keeping this evolution in the scheme so that we can keep reaching out to the needy and poor patients.
Thank you for that overview. And I must say that I've had several interactions with you, of course, and several other people at NHA about PMJ. And I'm always struck by the level of openness about reviewing the performance, coming up with ideas of what can be done, even on the private sector part. I have seen both sides of arguments, some private players being not happy, but then there is always willingness to engage and say, what can we do to bring you on board? And I think that is reaping benefits in the last couple of years. You talked about 32 states being on board out of 36, which itself is, I think, great achievement given the level of federalism that exists. And health, I guess, is also an important topic, right, for state governments to show their mark or their signature. And I guess there is that federalism at play. What are the challenges, if any, that you now look and are different from what you imagined the challenges to be? It's always the case when you're planning something, the mental model is different. And then as things evolve, you realize that something that you thought could be challenged, are easily overcome, but there are some unexpected challenges. And I was wondering if there is any of that sort that experience has told you now.
I think we can say with fair amount of confidence that Ayushman Bharat PMJ has now by and large stabilized. And those initial hiccups which we were encountering quite frequently, they are not there. Now the challenge is to keep evolving with the needs of the society. For example, we had if I can say it is a challenge, during when the COVID was announced, pandemic last March. So we didn't. So there were changes in the way healthcare is provided. All of a sudden, you had PPEs, isolation, less number of patients coming in. So the whole health economics got changed. So we adopted our packages to that. It was a learning curve which we adopted, and also issued a few guidelines for suitably compensating these hospitals, particularly private hospitals, as the COVID progress so that the treatment can be provided properly. At the same time, we also noticed that differences in the way claims are settled across India. Some of the states are on trust mode, some are on insurance mode, some are on mixed mode, and there are always pros and cons of these various options. So some healthcare providers were not happy with the way claims were either rejected or partially accepted. So we went on to develop what we call as standard treatment guidelines and then proper checklist to bring the pan India uniformity, so that the decisions become more and more predictable and objective, rather than making somebody in charge of some discretionary kind of decision. So it's I will say still an evolving state. It will continue to evolve, and we already have a second package master which we have rolled out, and we have already started thinking about third one, which will take a couple of years, but it's going to be a long exercise, so that we at no point of time hospitals should feel that they are not being suitably compensated, and at the same point of time government auditors should not feel that we are paying too much to hospitals. It has to be a very fine golden balance.
Got it. Got it. You also talked about how fee for service is not a right approach for a large scheme such as this, and even developed countries have faced the disadvantages of fee for service when you have a large program. And we've come to a packaged sort of formulation. How long do you think is the journey from here to anything such as pay for performance, value-based care, value-based payments? And what do you see that trajectory to be? What are the internal plans or movements that are happening to go towards that?
Yeah, one thing, even now we have multiplicity of mechanisms and schemes running within the government. Many of them even now on fee for service model like CGHS. And so we have some challenges, like the same hospital is catering to two different government of India schemes and working in two different models. So right now we are considering how we can move forward by making this as an umbrella scheme with maybe different packages and different schemes depending on the kind of beneficiaries and benefits that are assured. So that is one area which we are working right now, so that this level of uniformity increases even further. And be it a CGHS, be it armed forces, be it railways officer or PMJ, and then there are so many schemes in various states which are an extension of PMJ, if I can say so. So all these schemes, they ultimately merge and go on the same IT platform and start following the same processes, and it will improve the ease of doing business of healthcare industry.
Thank you. I think that's a good segue into our main discussion, which is about the IT platform or the IT ecosystem. I've been again observing the evolution of NDHM, and before that the National Health Stack. And again, I'm struck by the amount of public consultation that has happened on this. Draft is put up, comments are invited, and there are roundtables with industry players, and it has taken sort of substantial effort to have everyone on board. And yet, I think the topic is such that different people have different notions of what NDHM is. And so I thought, at the risk of being a bit pedantic, if you can start by describing in your view what NDHM entails, what its core components are. Once we have that clarity, then we can proceed with the discussion.
To define NDHM in a short span of time is difficult, but for the information of the audience, I can say that it's essentially an implementation of the National Digital Health Blueprint, which was released by Government of India in 2019, which itself took a lot of time to come out with. It was after extensive stakeholder consultation. NDHM in short is we have to understand peculiar scenarios in India. So if you take example of countries where digital health is really doing well, one gives the example of Estonia. It's a small nation. Then UK. But then these are the cases where there is a uniformity of digital health solutions across various healthcare providers, hospitals, laboratories, and doctors. It is not the case in case of India. So we have different managements handling, as I explained, in a federated environment, our hospitals. Then health is a state subject as per Indian Constitution, and we have a thriving private sector, and we have a huge variety of healthcare solutions which are in the market. There are, at the one end, we have a standalone clinic in a rural area which is absolutely no internet connectivity or computer, and on the other end we have top end public and private hospitals using the latest state of the art technology. The challenge or the task with INDIHM is to integrate all these disparate elements in a country of 1.3 billion people together in a way that if I go from one hospital to other hospital, which may be under different management, which may be using different digital systems, the doctor should be able to access the medical record of the patient completely. The longitudinal medical history should be available, which will be across various hospitals to the doctor at one place, and doctors would realize the importance of having complete history. Particularly in case of emergency medicine, a lot of time is spent on collecting information rather than treating. So this will provide a huge significant improvement in the quality of healthcare. Now this is just a one uh, point that we are trying to address. When the data is sitting across all over India in various servers, various solutions, uh, it makes sense to aggregate it and analyze it for research, evaluation, and public health interventions. But at the same time, we have to take care of privacy, security, confidentiality, and the consent of the patient, because it's very sensitive data. So that is another challenge that we are trying to address. So how do we do this? So we have actually built a few core building blocks. The every individual is entitled to have a health ID, which is a randomly generated number and unique one. And every healthcare provider or healthcare professional, doctor, nurse, hospital, laboratory, and so on and so forth, they will be having unique ID, and these are the only basic modules which will be managed by the government. Once that linkages are established across various digital health ecosystem, everything else it's so that data or information in different healthcare with providers, it can be linked. It remains where it is. So we call it a federated storage model. But as per the requirement, it can be combined and pulled with the consent of the patient to provide the proper treatment. And at the same time, decision making becomes data driven, evidence driven, since we now have a measurable data.
Got it. So, I mean, it is indeed a complex situation, right? You've got, as you said, a highly varied, heterogeneous, fragmented health system. Providers are large and small. And a lot of them may or may not have a unique ID depending on how states have implemented the Clinical Establishment Act. I guess that, so the starting point is not very clean. You need to bring all of them on this platform, give everyone a unique ID, and so is the case with patients. And only then the flow of data in a seamless fashion makes sense. So just to build on that, are there certain guiding principles or philosophy that you thought through and was the North Star around which this ecosystem was being built? Because you can't overly specify this system, right? Given the nature of the context that you described, you probably got to have some core elements which are invariant and then allow for a lot of flexibility. How did you approach that situation?
Fine. See, it is absolutely correct to say that we cannot lay down very stringent guidelines in black and white for countries such as ours. Also, it is important to note that this participation in this initiative is purely a voluntary initiative. We don't want to this become a command-driven system. We want it to evolve as a demand-driven one. And the participation is voluntary for hospital, doctor, and individual, all of them. But I'm very sure, given the advantages that people will notice as this mission evolves, they will start joining. This is one. Second, we don't want to focus only on treatment part of it. So the whole wellness or healthcare is under the umbrella. So it starts right from the time when you get your first vaccine, or probably even during the ANC of your mother. That's the start of our build-up of medical records. So we look towards the holistic kind of picture. Next point is we have to consider one side we have good big metros with good infrastructure, but we have to also take care of hilly forest and tribal areas of India, and that's why we also need to have uh, modules which will work fine even in these areas. So we can have offline module which will capture the data and push it once the network is there. So all these principles we are following, and these are elaborated in detail in the National Digital Health Blueprint. But we, while moving forward, are ensuring that all these areas are also taken forward. And I'm very happy to tell that we have started pilot in 6 union territories. So Ladakh, Andaman, these are really difficult areas to reach. They have also responded positively, and we are making a significant progress there.
That's really good to know. While you were describing these different building blocks of NDHM, I couldn't help but notice some similarities with how the fintech ecosystem is also evolving in parallel. Today I can just make money transfer on my phone, and this UPI as an interface to transfer funds came up. And I wonder if some of that was taken as a benchmark, or if not benchmark, at least an example. And I have pushed back people in the past when this discussion comes up, saying healthcare is not finance. You're not just transferring rupees. It's much more complex. So I was wondering how you strike a balance between taking some elements which seem common, but then saying no, others actually healthcare is very different.
Wow, this is a great example, actually, very good analogy. So taking forward that same example, UPI provides a connectivity between different financial institutions, and it does not control these institutions, but it provides a platform for development of the ecosystem. This is exactly what we are trying to do, and India is fortunate with this experience of finance sector, and also the strong base of Jan Dhan, Aadhaar and mobile. We are in a very good position to leapfrog into this area of digital health. There are one difference will be, while it is quite easy in the fintech ecosystem, because the data which we are exchanging, it's machine readable and it's predictive, so it's mostly numbers. And what happens in case of medical science, you will have X-ray images traveling, then you will have PDF files, then free text, then standardized texts like ICD or SNOMED CT. So it's a mix of the machine readable, non-machine readable, standardized, non-standardized, structured and non-structured data, which will be exchanged. So in fact, it's a more complex system, and it will take some time before we reach a level where the analysis of all this data becomes really very effective. To start with, we will be starting with the analysis based on machine readable data. So there are many similarities and a few dissimilarities, which makes it even more challenging.
Yeah, no, I can see that, based on your earlier comment about the data is stored in a federated fashion and the patient can authorize. And I was thinking, when I'm transferring money from one account to another, I am as an individual authorizing that 100 rupees be transferred from account A to account B. But for me as an individual, it's very easy to understand 100 rupees, right? It's a number, it's money. But if I'm authorizing one doctor to transfer my medical records to another doctor, it's not that straightforward. So beyond the technology complexity that you described, also cognitively, an individual may not fully grasp what are various elements, what is the information being conveyed, how much of it should be conveyed, not conveyed. And I guess that leads to complexities of, as you described earlier, privacy, security. Although we are a very open society in some ways, right? Everyone talks to neighbors, everyone talks to extended family about everything, about health. But there is a discomfort, in some quarters, that if this data is out there, will it be used against me tomorrow to increase my insurance premium, to lock me out of insurance plans, and I wonder, how do you address those concerns?
So, absolutely a relevant question and a good question, I should say. See, privacy is at the heart of this development of this particular ecosystem. So, fundamental principles, if you notice, when I said that it's a randomly generated ID, it is not possible to identify a person from ID or a doctor from ID. One, two, I mean, so privacy by design, that's the concept which has been accepted. Secondly, due to federated data storage model, we are not compiling any central repository of data except the list of health IDs. So there is no repository of medical data anywhere which is coming up in this particular mission. So data remains where it is. And we are going to access it. I mean, the doctors will be able to access it only when the patient gives proper consent. Now, even now, you have to see this system as a electronic version of existing physical system. Even now, a patient goes to a doctor, he goes with the records, his files of other hospitals, and then he presents it. In general, I would say that in India, 99% of people will not probably bother due to our cultural background about sharing all the information, but we have to take care of 1% of person also. And that is why we are allowing consent to be given in a granular and a uh, fragmented fashion. So if I go to a hospital, which I feel that the data related to my psychiatric disorder or sexual health diseases, it is not relevant to the doctor, then I have that option of withholding that consent while giving access to all in the record. Then I also have authority to withdraw the access, even if it is given before the time is expired. So the patient is ultimately the master of his own data. Now there will be a question obviously from doctors, why they are not being provided with all the data, and why every time patient's consent is required. Now this is a very larger ethical and legal question, but we are not changing the rules of game. Even now the rules of game say that it is the patient who decides how much history is to be provided, and generally they do provide properly. I don't see a reason why it is hidden. It's history taking is actually said to be art within the medical science. So, and this will definitely enable patients to provide a better history, complete history. And a lot of times medical records are simply misplaced in your homes and all that. This will be secured at one place. So we will ensure that complete history is provided, and at the same time it is provided only after the person gives explicit consent. Even when we think of using it for any analytical reasons, first thing that we are going to do is to define protocols for aggregation and anonymization. The individual history won't be disclosed to anybody. It will be only numbers, the total, the statistics, which will be used for any decision making, and that too after properly laying down protocols. Now, coming to the question of health insurance company misusing or some other company misusing, this is not going to happen because we will allow this information to be used only for public purpose, and it's not going to be used for commercial reason. So this we have explained to health insurance companies as well, that they should not look forward to this mission as something which will allow their actuarial analysis to be even fine tuned. That's not going to happen. It's just a digital platform to connect different stakeholders in the healthcare ecosystem. That's it.
That should calm a lot of nerves, people who are attending and also other people who are curious. Thank you for that. That also makes a switch from one stakeholder, which is the patient and family, to another stakeholder, which is providers. And the digitization of healthcare is a complex project across the world, not just in India. You talk about developed countries, developing countries, underdeveloped countries, tech-savvy countries. It's just a very complex situation. And we have today a lot of players who are, on the entire spectrum of digitization from 0 to, let's say, 90%. Nobody's 100%. And some people are claiming to be paperless. One is the challenge, of course, to, provide a platform which envelopes all of these differing statuses, right? So technologically, it's a challenge. But I'm wondering on the behavioral management side of things, right? You talked about you're not going to impose this on anyone. So are there any carrots and sticks in the equation to encourage adoption? What is in it? And I can give you my example. I've been working with the TB program, National TB program, for quite some time. And they developed a system called MIHM, which was meant to keep records. It's not whole records, but just TB related information. And for private providers to use that platform to notify a case, right, is a huge challenge because they don't have computers, they don't have support staff. So if you could talk about how you are foreseeing that challenge and what are the tools in your armor to increase adoption there.
We have to understand the incentives that a person should have to join this ecosystem. So why a citizen should join? The reasons are obvious. I can immediately search for the doctor or hospital suitable to my requirement within my budget, within the distance, either physically or through telemedicine, using the being the part of the system. I can ensure that all my medical records and my family's medical history is kept at one place. I just explained, won't go into details. For a healthcare provider, this will improve the quality of healthcare, the diagnosis and treatment tremendously, simply by having all the medical history available at the one place. And this is where we are lacking in a big way. It will also improve the ease of doing businesses, doing various processes, getting various permissions. For example, we have a healthcare facility registry, and we have captured essentially only minimal information, which we are making available to all the authorities. There are more than 60 authorities which grant different types of permissions to hospitals. So we are providing that access to all these authorities so that hospitals don't end up applying 60 times for 60 different permission with the same information. So this kind of platform is not only for providing healthcare, but for addressing all the associated issues of the healthcare ecosystem as a whole. So we are developing a new concept, like we will be having a concept called healthcare verifier, healthcare facility verifier, who will verify how many beds are there in the facility. So that can be used by the insurance company, for example, or some empanelment agency to take quick decisions. So I think ease of doing business is one thing which will improve a lot. Secondly, the data available will make it very easy to use our limited resources of our country to be properly used, which specialty to be opened in which area, how many doctors are there in a particular state versus other state, so how many medical seats should be there in various. So all this decision making, which goes even beyond the realm of actually providing the healthcare, to develop the ecosystem, it will be very easy to do. I don't see any major challenge. Obviously, you gave the example of 0% to 90%, and we encourage this travel from 0 to 90, but we don't make it mandatory, because the doctors, it's like involves learning as well as unlearning. And one may recall when the emails were initially, they 20-25 years ago, when emails came, a lot of people used to write letter, scan it and send it by email, because there was no concept of typing and send it across. Same thing happened with WhatsApp also, particularly regional languages. And once the regional keyboards they emerged, you started typing in that. So this is a evolution which we are looking forward to. It's not going to be overnight disruption. And obviously providing healthcare is primary, and we cannot put it at risk just because we want to roll out a particular mission.
So I took two important things from it. Just because it is technology, one should not expect a boom, right? Like, you flip a switch and something is going to happen. There is a lot of behavior change, system transformation that's going on there. And eventually it's about health. While I'm sure there are a lot of people excited about the technology on this event, but it's about providing better care facilitated by this technology platform. And I think that needs to be kept in mind. We're getting towards the end of our conversation, and I want to leave enough for audience questions. But if we can bring the two together, we talked about PMJ first, Ayushman Bharat, and now the Digital Health Mission. Do you see any synergies between the two? And you mentioned incentives, and I'm wondering if wheels are turning, where we say, hey, the fact that you're part of PMJ could you do this in NDHM and vice versa? That will be helpful to know.
Yes, very much. In fact, PMJ is going to be the first public health program which will become a part of NDHM. It's almost at the final stages. So we can immediately start with accessing the health records uh, of PMJ treatments. So the same patient, if he is going for non-PMJ treatment, let us say in some other hospital, he will be in a position to access those records. So that's the start of it. It is one of the larger schemes which we are integrating. Nikshay, you spoke about that also. We have started integrating. So all these healthcare schemes, they end up as a health information provider, and a ready-made data, rich data, huge data, which we should not ignore, that can be straight away onboarded as a stock of information while the flow will continue in the future. So it gives us certain critical mass to get this initiative launched, and PMJ is a very good example of that. I can give you one more example. Now that we are going for COVID vaccination throughout India in 60 plus and 45 plus comorbidity patients. So this network, this information and this digital information about PMJ hospitals, we could simply, we have used this in the COVID application so as to reach out to maximum people in shortest possible period of time. And it solved a lot of problems, which private hospital is to be selected, and how do you engage with them. We already have a system, not only IT, but from administrative point of view, we know the nodal person, we know how they work. So there are a lot of areas of synergies between all the schemes and programs and governments, which we must leverage upon, and we are trying to do that.
Perfect. Thanks for that information. I think let's open it for questions. Some people have already started typing in, and I'm going to pick a few that have common themes so we can answer them in an efficient manner. Dr. Praveen, there are a couple of questions on the timeline, so as to speak, the plan going forward with NDHM. One is about when do we expect this rollout to happen beyond the UTs? Currently it's in UTs, but what's the roadmap going forward? And one question is about specifically on the health claim platform, component of the platform. If you could speak to those two timelines.
Fine. So right now we have started pilot in 6 union territories. We have around, we have reached almost 1 million health IDs and a few thousand doctors and hospitals. But this will start making sense only if the health records start getting linked with these IDs, which has started in these 6 UTs. And we are getting more and more hospitals, doctors, and HMIs getting linked with us. And we hope that, so it was a learning phase, which we have made some changes, and now I think we are ready to go for nationwide rollout. We are just waiting for green signal. It can happen in a couple of months max after the formalities, including financial arrangement for that. So we are really not far from the nationwide rollout. Number second, I think you asked about health claims platform. So there are like PMJ uses its own what we call a transaction management system as its healthcare platform. Some big insurance companies have their own platform. Some companies don't have their platform. We are discussing how we can create electronic healthcare platform as a public good, which will bring in uniformity and again improve the ease of doing business for healthcare providers and insurance companies, improving the speed, decreasing the discretion. Uh, so I think that is also coming soon. It's almost in final stages, the discussion and concept. But healthcare platform is probably going to be a very important component of the NDHM, no doubt.
Perfect. There are a few questions around patient consent and patient education, I think rightly so. One question is about, are there efforts being taken by NDHM and the government to have an information campaign, awareness campaign, because some implicit consents are becoming explicit now. We are explicitly saying the onus is on patients. So that's one. And the second is a variant of that, which is what about special cases where patients may have, let's say, mental challenges, mental health challenges, or developmental disabilities, and they may not be able to give consent. So is there a framework for guardianship and a guardian can roll out? So if you can address those two questions.
Yes. See, we should not probably underestimate the capacity of our population to adapt to technologies. We have seen how apps, from simple apps to complicated apps, they are being used by even illiterate persons in India. Having said that, we cannot also keep it only to them to learn it. So we start developing. We have actually developed a few IEC modules. Our plan is there. We are ready with the IEC plan to engage with the community doctors and paramedicals to make them adopt to this particular system. And this will be a continuous process. And we are envisaging that private solutions. So in case of UPI, we discussed, we have Paytm, Google Pay, Phone Pay, and all that. So they also come out with the newer products which have better and better user interface and user experience. So obviously we encourage these players to come and join the ecosystem, and the one which is the simplest and easiest and most convenient one probably will move forward. So I think it's a complementary kind of drive that we are looking forward to. At one end, we are trying to educate the people, and second end, the companies which will come out with their solutions, they will try to make them simpler because of the competition. It's an open competition, and that should help the adoption of newer technology very fast. I can tell you that we have already more than 9 lakh, almost touching 1 million health IDs generated across 6 small areas. Really, these union territories are really not big, and I could notice people generating their health ID on their mobile, on their own, within a matter of 1 minute or 2 minute max. Then there was a question about special cases.
Yeah.
So mentally challenged, otherwise accident cases, comatose cases, those who are not in a position to give consent. So there is a concept of guardianship, who will be a legal guardian, can be relative or can be friend also, who will be taking decisions. The way it is happening right now, even now for physical records,
Yeah.
this is what is happening.
Yeah, got it. No, helpful. Two or three questions talking about one thing we had discussed earlier, which is movement from fee for service to, let's say, pay for performance or value-based payments. And the question, one of them is, what is being done to improve quality of services per se, given that PMJ as a payer is growing in size? So what are the actions being taken there? And second, related to NDHM, is there a plan to use the data, as you were saying, for research? But one specific aspect of research is health technology assessment, which services are cost effective, which interventions are not cost effective. If you could talk about those couple of issues.
See, quality of healthcare is a very important and a tricky area. And it is very difficult to define quality in biological sciences. So there are certain steps that we have taken. For example, in case of PMJ, we have given certain certifications to hospitals depending on the facilities and infrastructure that they have. So, and we pay more to those hospitals having better facilities. So that takes care of some part of quality. Then we have tried to, we simply cannot put it in black and white. Medical science cannot be done that, but we have tried to prepare a checklist or standard guidelines for various diseases, so that just because a certain payment is assured, a patient doesn't end up getting below standard treatment. So we have a certain minimum checklist for each of these packages, which ensures quality to a certain aspect. So, and then obviously there is an element of constantly seeking feedback from the patients, and a grievance redressal mechanism is in place. But I understand it is not as easy as it may be in, say, telecom sector or a banking sector, because there is always professional judgments of two doctors may differ, and both of them may be correct also. So this is an area which we have to tread with caution, but we cannot ignore also, and we are certainly moving towards that direction.
Perfect. I guess depending on the mix of our audience, there's several questions and curiosities around use of data for research. An example is given about the Indonesian system where a random sample is made public of records, anonymized obviously, and then people can use it for research purposes. What is your thought currently? Is it going to be that model, or would selected researchers have to approach with a proposal and there's an approval process, etc.?
Frankly, this has not been finalized as yet. So it's still at a thought level of thinking, and we have not finalized any model. But one thing is very clear, that we don't want to sit on the data and do nothing, because it's a crime in this IT age. And but at the same time, we have to also make the fine balance with consent, privacy. So we will come out with the guidelines so that proper research is not hampered, but at the same time, data is not selectively used by a particular vested interest for its private benefits. So we will come out with those guidelines. We'll put them in a public domain also.
Got it. Again, I'm trying to combine 2 or 3 different questions. As we said, data is not simple in healthcare. There is hospital data, hospitalization data, but there's also a lot of behavioral data, demographic data. And I'm not talking so much about privacy, but the fact that knowing all that demographic data, knowing that I'm a smoker or not, has an implication on my potential health risks and whether I respond to a treatment or not. And what are the current provisions to say we should try and capture all these different kinds of data, not just hospital data? I think some questions are about that. So the value of primary healthcare data and preventive health data is immense to reduce costs in tertiary care. So how is the NDHM framework allowing for that or facilitating that?
See, one of the basic principles of NDHM is to focus on wellness, not on only medical care. And primary health centers, sub-centers, ASHAs and ANMs, they are going to be an integral part of this system. We have already started developing offline modules for these stakeholders. And when I say that NCD is going to be integrated, so chronic disorders, non-communicable disorders, or NICSHA is going to get integrated, RCH, the data of vaccination. These are areas where we have an overlap of preventive and curative medicine. So all this data we are trying to use, integrate, and obviously everyone, it's a age-old saying, prevention is better than cure. Obviously, primary healthcare has to be the at the base of everything. And so we are actually working towards that, so that we can in the later phases understand the risk profile, which particular group is to be targeted or kept under surveillance for which type of diseases, depending on. So we have a very different categories of, for example, women who end up having cervical cancer and breast cancer. Can we do proper profiling so that we can target our breast examination and pap smear campaign accordingly? So this is certainly going to be one of the ideas which we want to develop upon further and make use of in order to have a better preventive healthcare.
Correct. You talked about breast cancer and cervical cancer, and that reminds me, some of the work we do with Tata Memorial Hospital. I think they have been partnering with NHA to develop guidelines for cancer treatment and link payments to those guidelines. They also work on disease registries, and one of the questions is about registries. How is that being planned? If you can explain more details of NDHM data being used to create disease registries, given that there is everything about privacy and security and all that.
Okay. We are I think this question has more to do with regulatory and legal framework rather than a technical. We are ready to create such registries, and it will require further consultation, because there are always pros and cons of creating such registries of patients. It is already being done in certain cases. We are also public health programs. We are doing it, and whether it has to be expanded beyond those programs is a decision which will be taken only after extensive consultation. Because we don't want a registry of every single disease also to be prepared. We have to balance the efforts involved in it, the outcome, and also on the one side, a sense of privacy that one may have.
Got it. Got it. I guess there is a recurring question, although we've tried to address it, but the question remains about physician adoption of NDHM, one. Second is ongoing use of NDHM to enter data. Because as we know, if the data is rich, then you can do more with it. And then there is cost to upload data, cost to enter data. So what are things that you are thinking of to bring people on board and keep them on board?
Okay, and I would like to club it with additional investment required.
Yes, there was a question about expenses as well. Yeah.
So, see, I repeat, we are not going to increase the efforts of data entry to any significant extent. How? Because all the hospitals which are already using electronic systems, they will continue to work as they are right now. What is happening is that only their computers are getting connected to a national network, nothing else. So you as a doctor provide a treatment, type certain medicines, write the history and some clinical notes. You are doing it even now, and you will continue to do exactly same thing. What is happening is now that particular information is accessible to other doctor after consent. This is like a scenario where you already have a laptop or a computer, and you end up getting an additional internet connectivity, so that what file you type or create, it can be pushed or retrieved from other computer. That's it. So I don't think there is any significant additional expenses. The expenses are essentially for hardware, which we are doing even right now. The expenses are for internet connectivity, which we are doing even right now. What is happening is that by adding that linkage to health ID or doctor ID and hospital ID, the records are now available. We know we can locate the record where it is available in the ecosystem and pull them. So there is no significant increase in the work, except which hospitals have already experienced while shifting from paper to computer, which is nothing to do with NDHM.
Got it. Got it. So just to quickly follow up on that, the two types of providers broadly, those who have some kind of an IT system, and for them it is, hopefully plug and play. For those who don't have an IT system, right, who have a solo provider practice, maybe a very, very popular doctor in a small town, but has only a couple of rooms and maybe just a very skeletal staff. Do we have to then co-opt them differently because they may not have these infrastructure, and who knows whether they are interested or inclined or not? What would be the playbook there?
Yeah, actually, after this NDHM was launched, we are having several round of interactions with the digital health players, including those in Hyderabad and Bangalore and Pune and NCR. And many new initiatives in this field of digital health have already started. More than 400 of them have already integrated with the sandbox of NDHM. And this is one area which requires a special consideration. So we have our government HMIS of NIC. So it is also undergoing a development to take care of requirements of a smaller healthcare facilities. So we may have a facility like a doctor who is assisted by compounder, come clerk, come attendant, come receptionist, everything bundled together. So we cannot increase his processes while trying to bring them on board. And that particular product, I'm sure, will come out, and whichever product is most convenient, obviously doctors will start using them. And that's the reason I said that from the day one, we don't expect them to switch to computers totally. we are okay to start with if the same papers that they are writing down are scanned and uploaded to start with. But I have seen even in government hospitals where at least OPDs are totally paperless now. So papers are not used. So that shift we are already witnessing. The difficulties are there in IPD treatment to some extent because you move from bed to bed, and that is where the role of data entry operator and some such additional people comes. I think this is also going to generate a lot of employment in a way.
Yeah. I mean, what is underlined again in your comment is that NDHM is an ecosystem, and so if it is designed correctly, it's going to be generating many solutions. You don't have to generate those solutions. The private players can generate technology solutions which are appropriate for a certain segment of providers, and providers will adopt if they find it useful. I suppose there will be a role to play when some adoption has happened and one can talk about success story, right? Because people learn from each other. If I'm a provider, but you have done it and you found it useful, and if you're willing to speak about it, then I think it has a word of mouth effect.
Certainly. So we are looking forward to encouraging newer and newer products. Probably we may end up having startup challenges and such competitions, which will make people aware about the newer products. So we will also come out with some reference applications. So UPI started with Bhim, and after Bhim, so many applications. Bhim itself is a wonderful product, but then we didn't keep it a product having monopoly over this network. So we allowed other players to come out, and then they came out with their products, evolved it as per the requirements of the society. Same thing I see happening in this particular sector as well.
Got it. I guess we are very close to running out of time, and I know that you are running in and out of meetings, so I don't want to spill over beyond 4 p.m. We've had a very engaging audience, a lot of questions. We've tried to create themes from questions and ask common questions. So my apologies to the audience if they think their specific question has not been answered in the way they asked it. But as I said at the beginning, Dr. Gedam and his team at NHA is very open, has always invited comments, consultations, and I'm sure there is a channel available for public to use to reach out to you, Dr. Gedam. But it's been a pleasure to have this conversation. Thank you so much for your time.